latest update in hypertension. Introductions. As per WHO, nearly 63% of total deaths in India are due to non-communicable diseases, of which 27% are attributed to cardiovascular death, which affects 45% people in the age group of 40 to 69. Raised blood pressure is among the most important risk factor for cardiovascular deaths. Moreover, it remains poorly controlled due to low awareness about hypertension, lack of appropriate care through primary care, and poor follow-up. In India, the prevalence has also gone up over 30 years to 38% in men and 32% in women, from 29% and 28% respectively, according to WHO. Despite that, nearly half of the people, or 51% of the men and 41% of women with hypertension, are unaware about conditions. Additionally, over 62% of the men and more than 53% of the women living with hypertension did not get treatment. Medication was used to control the blood pressure in fewer than 1 in 5 men and 1 in 4 women with hypertension worldwide. International Society of Hypertension has released the 2020 Global Hypertension Practice Guidelines. The inclusions of optimal and essential treatment paradigms attempts to address the issue that in resource-poor settings, optimal care refer to evidence-based standard of care, and where essential standard refer to minimum standard of care to allow specification of essential standards of care for low resource settings. The American Heart Association or American College of Cardiology has released a scientific statement in 2021 offering new guidance for management of stage 1 hypertension among patients with low atherosclerotic cardiovascular disease risk. Among low risk adult, that means atherosclerotic cardiovascular disease or 10 years CVDs is less than 10%, with stage 1 hypertension, that means blood pressure 130 to 139 systolic and diastolic 80 by 89 mm of Hg. Management starts with non-pharmacologic therapy if blood pressure remains uncontrolled at 3 to 6 months. Consider starting pharmacologic therapy. Lowering systolic blood pressure targets down to 110 to less than 130 mm range substantially reduced cardiovascular adverse event in the STEP randomized trial, affirming the sprint findings for an older Chinese population among some 8,500 patients ages 60 to 80 years in China. The intensive target trimmed 26% of the composite CVDs. Findings from now a second major trial supporting a lower target could unite the guidance, which even among the US professional societies range from threshold of 130 to 150 mm of Hg. With regard to prognostic value of ambulatory blood pressure monitoring and nighttime blood pressure monitoring, the 2018 European guidelines on the management of arterial hypertension recommended that the diagnosis of hypertension should not only be depend on office blood pressure measurement, but also on out of office measurements such as ambulatory blood pressure monitoring or home blood pressure monitoring, 24-hour and nighttime BP measurement were associated with greater risk of mortality and composite of cardiovascular outcome. Thus, they may be considered as the most relevant measurement for estimating cardiovascular risk. For every 20 to 10 millimeter increment of, that means systolic blood pressure 20 and diastolic blood pressure 10 increment of at night, the risk of mortality increased by 23% and the risk of cardiovascular events increased by 36%. So most patients with hypertension require lifelong medical therapy to achieve optimal BP control. 2018 European guidelines equally recommended 5 classes of antihypertensive drugs. Considering high non-adherence treatment, the importance of combination treatment is particularly highlighted to improve the adherence to therapy and BP control. Therefore, the 2018 European guideline recommended, especially in the context of lower blood pressure target, to start antihypertensive therapy with an initial dual fixed dose combinations of SC1 or ARB plus CCB or diuretics. The HYGEA study represents the largest study that tested nighttime antihypertensive treatment in this trial. Chronotherapy was associated with a significant reduction in endpoints, including death. The HYGEA chronotherapy trial tested whether right time therapy in comparison to usual upon awakening hypertension therapy exerts a favorable cardiovascular risk reduction. The largest study included a total of 19,084 hypertensive patients during an average follow-up of 3.6 years. 1,752 participants experienced the primary CV outcome, and ambulatory BP measurement was performed for 48 hours to collect data on how BP differed during sleep. The RR reductions of cardiovascular events was significantly improved for nighttime treatment when compared with awakening treatments. Thank you.